I really appreciate having this time to talk a bit about my work, which is with people who are often neurodivergent in a bit of a different way from how we've heard about today, usually in relation to different neurological conditions. I'm going to talk a bit about what I've learned working with these client groups, relevant for those particular conditions, but hopefully some parts, as we've been learning today, that neurodiversity is all around us, we all experience it, some relevance to all the people we work with. So a little bit of a plan for what I'm going to cover today. I'm going to be introducing this idea of acquired neurodivergence, changes in mental functioning, cognitive change that are due to illness and injury, rather than some of the conditions we've talked about already that are there from birth. I'm going to talk about a couple of examples. This part of the presentation is a bit fact-heavy. I'm going to move into some more clinical examples, thinking about just what the experience is like for GSRD people, and then moving into thinking about practical ideas for making therapy more accessible. Hopefully that bit will be a bit more interactive. In terms of sort of trigger warnings, there's a couple of images that are brain-related, they're not graphic. There's a bit of discussion around health stats for LGBTQ+ people. They're quite stark. I guess today might have been quite a heavy day for some people. We're talking about a lot of experiences that are quite personal for a lot of us. So just to look after yourselves if you need to step out. Happy to talk to people afterwards if you've got any thoughts or questions. A lot of the material in this presentation is LGBTQ+ focused. That's because that's a lot of my clinical experience. I've tried to bring in other parts of diversity where I can, but it's definitely an area that could be expanded. I'd welcome any feedback on that. A little bit about me before we get started. I've trained as a clinical psychologist, and during my training and after, I've been working mostly in neuropsychology, so kind of the area of psychology that relates to links between the brain and behavior, relationships and mood. And clinical neuropsychology will be the application of that working directly with people who've got conditions like brain injury. There's some parts of my work that probably look like a lot of other kinds of talking therapy, working one-to-one, doing therapy with people, but it's often adapted to their health needs. There's some parts of my work that probably look a bit different, like doing cognitive assessments, using IQ and memory tests to get a pattern of someone's abilities, maybe to answer a question like, is this person developing dementia, or to inform their treatment pathway. I do a lot of work in rehabilitation, so I'm working as part of a team with occupational therapists, nurses, physios, where we're all working together to help someone increase their independence. That work can be quite creative, quite practical, so that can look a little bit different from your more traditional therapy. My work, a lot of it's focused on sexuality and gender. Some of that's to do with my own personal experience and background in activism. Also, a lot of my work's been in the NHS and seeing these areas really neglected. So I try and bring these things together. And I think the way I work individually is quite informed by neurorehab, neuropsychology. I bring in a lot of practical skills to my work to help people engage and also to implement some of the changes they want to make outside of the sessions. So this term acquired neurodivergence is not a common term. I heard it referenced a little bit earlier in some of the other presentations. I think we're all really familiar with what neurodivergence means, kind of mental or brain functioning that's outside of what's considered neurotypical. And this discussion about it being a wide umbrella that covers many conditions. We most commonly think of neurodevelopmental conditions, autism, ADHD. And this term acquired neurodivergence relating to people who develop these issues later in life, due to illness, injury to the nervous system. So that might be conditions that we think of as neurological, like Parkinson's, MS. But it's also relevant to other health conditions that have an effect on thinking skills, like living with diabetes or chronic pain. So this image, I don't know how well you can see this. I know the slides are coming up quite pale. Lots of acronyms. I won't go through them all, but this is one representation of all sorts of different things that could be thought of as neurodivergent. ABI, acquired brain injury, would be relevant to what I'm talking about. Epilepsy. Just to say that not everyone relates to this idea of neurodivergence as a widening concept. I think for us to recognise that conditions like ADHD and autism, they've been neglected, they've been stigmatised, and widening the umbrella isn't to say that those people don't need specialist support and understanding, but there can be shared knowledge and understanding between the conditions. Some of my brain injury clients, they present in some ways like an autistic person, but their experience is different and their journey is different. For my own clients, a lot of them find the term neurodivergence useful for understanding themselves, particularly as it's becoming more commonly used, for understanding themselves and explaining to others. Sorry. So what might be different compared to someone with ADHD or autism? Some of this is a little obvious, that people aren't born with these symptoms. They've got experiences of developing in a typical way. They'll have had memories of them functioning in a different way. And then something's changed. They're going through an adjustment process. There's a discrepancy between how I used to be, what I used to do, and now. That's very different from someone who's lived all their life with particular challenges. I guess the other difference would be that the symptoms aren't always static, that when someone has rehabilitation, they might see some improvement in their symptoms. If someone's got a deteriorating condition like Parkinson's, dementia, we might see a change, a decline in symptoms over time. Or we might see some variation and fluctuations, something like MS, where someone has relapses, maybe a burst of impairment, and then an improvement, and that changing again. So that will be very different from someone who's living with autism, ADHD, or other kinds of more developmental neurodivergence. So why think particularly about GSRD or LGBTQ+ experiences of this kind of neurodivergence? These are things that affect the whole population. They're not specific to this group. But there are some particular challenges that get thrown up when you're managing both sets of challenge, which is something I'm going to think about today. There are some health conditions that we see a bit more often in LGBTQ+ groups, and the intersection of different forms of discrimination and oppression, of ableism combined with homophobia, transphobia, biphobia. I don't know how easily you can see this image. I'm going to talk it through. I've just tried to pull together from the research some of the areas that come up thinking about neurological health, brain health for people who are LGBTQ+. Some of these are relevant for all kinds of health. Some of them are a bit more brain specific. So over on the right, I've got parts that relate to services, discrimination in services. People aren't getting referred. When they are referred into services, they often meet with assumptions, hostility. People might fear this and not even want to see a specialist. When they do get into services, often there's a lack of specialist knowledge and experience of working with people like them. And that's particularly relevant if there's an added level of complexity for their condition, maybe due to their identity. I'm going to talk about that a little bit more. This term neurodisparity gets used, that in neurology services, people from minority groups aren't getting referred and seen. That's not just for LGBTQ+ people, that's for other minority groups also. And then over on the other side, more individual factors. Intersections of other forms of oppression that impact on health, economic disadvantage, homelessness, health-related behaviours, high rates of smoking, drinking, substance use, these all affect the brain. Certain conditions we see more often, I'll come back to that. Higher rates of poor mental health, both in terms of how that affects how you look after yourself and your body, how you advocate for yourself, trying to get a referral, but also how to tease apart what's related to mental health and what isn't. If someone's forgetful, is it because they're depressed, or actually is something else developing, or maybe a mix of both? Risk of developing cognitive difficulty. Some research that as LGBTQ+ people get older, they're at higher risk of reporting problems with their memory and other thinking skills. We think this might be to do with social isolation, not having the support around you that makes you more vulnerable. So I'm going to talk in a little bit more detail. Sorry, this is a little fact heavy. We know these inequalities exist. There are some conditions we do see more often that affect the brain, thinking about HIV. Some research suggests that we see stroke more often in lesbian, bi women, trans women on HRT. Injury to the head, people who are at risk of violence, be that sex workers, people experiencing domestic violence, violence on the street, harassment. These are all risk factors that can be higher for people in LGBTQ+ groups. And this topic about complexity, managing your identity and your condition, is a huge area that I can't talk about in a huge detail, but some examples would be if someone's on HRT, there are some interactions with other forms of medical treatment, e.g. epilepsy. Some different medications need to be considered. That might be particularly relevant if someone's self-medicating and doesn't want to disclose to their consultant. Dementia is another huge area. If someone's having cognitive decline and that's disrupting their sense of identity, maybe in terms of memory, they're going back to a time before they were out, they're struggling to remember who they've been out to, how to present, maybe they're having to go into a care setting that isn't open to their identity. High complexity that needs sensitivity and specialist support. I'm going to think a little bit about some of these conditions in a bit more detail, just to show that, I guess, the level of complexity and some of the detail that needs to be held in mind. So thinking about LGBTQ+ or queer people and the brain, HIV comes to mind. Early on in the HIV/AIDS epidemic, it was a particular risk factor, being a man who had sex with men. That's not so much the case now, diagnoses dropping in that group, but people living long-term with HIV, a large proportion are gay or bisexual men. And statistics that there's quite a high level of cognitive impairment in this group, some stats saying up to 50%. It depends a bit on how you assess it, how you measure it. There's a lot of people living with some degree of cognitive impairment. It ranges from people who'd be asymptomatic, so if you did a formal assessment, it would show up some areas of difficulty, but day-to-day they manage fine, right the way through to people who would meet the criteria for HIV-related dementia. And this can set up a bit of a difficult cycle where, say, someone's having problems with their memory, their concentration, and that makes it difficult to manage their HIV treatment. They're forgetting medication, they're forgetting appointments. That might be particularly the case if they need to conceal their medication taking from people around them. Maybe that means they're dropping out of contact with services, they've not got as good control over their viral load, they're placing them at risk of higher levels of cognitive impairment. This can cycle round, and I guess for this reason, services do tend to screen for these difficulties on a yearly basis, try and catch these problems. Often symptoms tend to stay quite static, they stay at a similar level, and with some medication they actually improve. Stroke, probably the most common form of acquired brain injury. A lot of us will have known someone in our lives who's had a stroke. The brain needs a lot of blood flow to it to function, and if any of those blood vessels get to block or breaks, leading to bleeding, that causes a form of brain injury, and the effects are really different depending on where in the brain the stroke happens. There's been some research I found in preparing for this that suggests that in lesbians and bi women, trans women on HRT, there is a higher reporting of stroke, particularly for women of colour. I don't think we really know exactly why this is, whether it relates to cumulative effect of stress on the body's vascular system, whether it relates to some of those health behaviours, smoking, obesity. We do see higher rates of stroke in women anyway because they tend to live longer. Just an interesting piece of information, something to bear in mind. Often with rehabilitation, people will see some improvement, but also there can be a risk of a second stroke. Sorry. I was going to talk a little bit about hypermobility syndrome, or EDS. This isn't a neurological condition, but a condition I see quite a lot in practice and personally in the community. So this is a hereditary connective tissue disorder. Affects the different systems of the body because we've got connective tissue throughout the body. So it's not strictly acquired, although quite often people don't know at birth they have this condition, and it might take a really long time to get a diagnosis. And sometimes there is some progression of symptoms of cognitive impairment changing. It's pretty common for people to talk about brain fog, feeling forgetful, difficulty focusing, and quite hard to tease apart, is this down to being in high levels of pain and really fatigued, or is there something else going on? There's been a little bit of research that found that actually even controlling the levels of pain, there were still some problems people were showing with visual spatial ability, with attention, with memory tasks, and I don't think we fully know why this is. Some suggestion it relates to dysregulation of the autonomic nervous system. So that's some of the more factual-based area. I'm going to talk now about what's it like being GSRD, having these difficulties. For some people, their difficulties relate to their sense of identity. For some people, it might look a lot like anyone else with these kind of cognitive difficulties. That day-to-day, there are the frustrations of errors, things that take longer, things that are embarrassing, needing extra help, being stigmatized. People not understanding your cognitive difficulties, thinking that they're put on or that you're not paying attention. People are often infantilized, treated as undesirable. A term that used to get used a lot that seems to be coming out of favor, sapiosexuality, this sort of rather ableist term about being attracted to intellect. What does that mean if actually your intellectual functioning is affected by your health? It's nothing you can do about it. And particularly for GSRD people, for LGBTQ+ people, you can think about just all the different ways in which reading cues visually, in terms of body language, in terms of verbal language, in terms of appearance, can be really important for finding your community, for interacting. If people talk about their gaydar, those little subtle signs that give you the sense that someone's like you, that can be really distorted or difficult to interpret if you're slowed down, if reading those cues is difficult. Also, is this a safe environment to hold my partner's hand? Can I process what's coming in to say, actually, maybe not? Getting those cues from other people that maybe this isn't the right place for me to be more out. Meeting partners, all of those ways of interpreting body language, eye contact that show interest, how to connect with a new partner when it takes you that bit longer. Maybe the signals get interpreted, but you've missed the moment. Both being able to read these cues, but also to give them off yourself. Talked already about HIV. Our clients who are accessing or really trying to access gender-affirming healthcare, huge cognitive load, chasing up referrals, perhaps informing your professional how to make a referral, chasing up prescriptions, particularly when there are shortages, blood tests, higher organisation, and some of our clients who have initiation difficulties, they might really want to do these things, but getting started is so hard, and they're getting behind on their life plans. Being in LGBTQ+ or other community spaces, they can be loud and hectic, but seeing a bit of a move to some more quieter or sober spaces. Also, if you rely on someone else like family to help you access these spaces and they're not supportive, you might be really blocked from community. It's high levels of memory demands that are involved in connecting with people, finding community, meeting partners, casual partners or something more serious. How does it come across if you can't remember someone's pronouns, if you keep forgetting, remembering someone's boundaries, their life circumstances, navigating consent? These take language skills. Thinking about alternative relationship structures, non-monogamy, we can joke about just the high admin burden of these relationships, diary planning, navigating in blended families. But these are really cognitively complex, and some people might need help with these things. They might need extra time. Relationship check-ins might need to be planned out. They might need notes for these things to be able to engage. These are just a few areas. Just touching here on some of the referrals that I get. They're quite varied, but often adjustment is one of the reasons people are getting in touch. They've had a diagnosis or they've gotten ill and they want some help with moving forward. Maybe they've got a mood problem or a behaviour problem that's related or it's complicated by their health. Or living with the health condition is just part of their experience. They've got a GSRD identity and they want to see someone maybe for something else entirely, but having knowledge of both those things is important. Also, as I said before, quite often I'm part of a wider rehabilitation team, so the referral might be about supporting someone back to work, maybe back into education, back to living with their family, where psychology is one part of that. Quite different referrals depending on whether it's the person themselves asking for support or whether it's, say, the team around them who's saying this person's not engaging, they need help, the family, different agendas there. So I'm going to discuss an example of someone I worked with, and then I'm going to discuss a case maybe altogether. So this was a guy in his 70s, gay man living with Parkinson's, progressive neurological condition, where there's a loss of cells to the dopamine tracts of the brain that are involved in controlling movement, but also a lot of other mental functioning. People often have a tremor, instability walking, some slurring of speech. So this referral came in when I was working in the NHS by the Parkinson's team. That Robert was behaving in a way that was causing concern. He's very flirty, but this had reached a level where this was actually getting in the way of his care, that staff were uncomfortable with him. He'd made some accusations towards staff, which they claimed were false, and people were refusing to work with him. And he did rely on carers coming in multiple times a day, so he needed that care support, and there was a risk he wouldn't get his care needs met. And there was a question about, is that just him being himself, or is this Parkinson's? How do we understand this, and how do we help him? So to start with, I spent a bit of time getting to know Robert, doing some one-to-one sessions. It's had to be quite flexible. In Parkinson's, the symptoms vary during the day. They're controlled by medication, then they're not, then they are. So trying to time the sessions to fit with that. Also trying to time the sessions for when carers weren't turning up right in the middle. Getting to know him and his background, he told me about a real sense of shame and a lot of experience of hiding, not accepted in his family, a lot of experience as an adult. He'd worked abroad quite a bit in countries where it wasn't safe to be out, but also even in the UK at that time too. And kind of at a point in his life where he just wanted to be himself, wanted to be out, but also quite scared. He's now having to rely on a lot of effectively strangers who come in to help him with intimate tasks. He doesn't know their background, and he was often assuming that they might judge him or want to withhold care. He was naturally quite a playful person. He'd been a performer, he'd been very academic, he was articulate. So these were parts of his personality, and he was pretty lonely. He'd really like to meet someone, but given his disability and his living circumstances, really limited in ways to do that. So part of my work was doing some cognitive assessment with him. Talking to him, he came across pretty well. It wasn't obvious whether he had memory problems or not, but when we did the testing, actually within about 10 minutes, often if I gave him words or phrases, he'd pretty much completely forgotten them, and that really framed what it must be like for him day to day, that a lot wasn't getting hold on to in conversations with others, with the carers. He also had a lot of difficulty on some of the executive functioning tasks of inhibition, where you have to hold back from being impulsive, from answering the first thing on your mind, from problem solving. He was quite slowed down as well. And I guess looking at the results, they were more than we'd expect from a regular 70-year-old man of his academic background. So it did seem quite likely that this was due to his Parkinson's, and it really helped us to understand a bit more of him as a person, bringing together his background, but also some of these results. These are some of the things we did. Some of them are more therapy-based, some of them outside of therapy. The Parkinson's team made some adjustments to his medication to try and get his symptoms under better control. With his permission, we're sharing some of his story with his care manager, just to try and build a bit more empathy for him and consider who might be the best carers to work with him in terms of their personality and background. Giving the staff some advice on how to enforce boundaries with him in a way that doesn't shame him. Being mindful that he's likely to forget. I think they started using some whiteboards as well to back up information. Something that really helped that wasn't in the therapy at all was him moving to some better accommodation where he could be more independent and have more social contact. He felt so much better and the behaviour naturally dropped off a bit. We did try and link in with local LGBTQ+ groups. They had a group for older people. Access was really hard, that it was age appropriate, but in terms of how he'd get there and how they could support him with someone with a significant speech problem, it was quite hard to find a right fit. He'd really enjoyed the one-to-one input, but we'd come to the end of our allocation, so we're looking at other options that might give him some of that ongoing interaction, maybe befriending, maybe local LGBTQ+ history project looked like some good options. I'm going to just think a bit now about practical ways of making adjustments for people with different cognitive needs. Some of these strategies and ideas, they're going to be a bit similar from some of the ones discussed earlier in today. They're useful for people with neurological conditions and health conditions. Some of them will be relevant for other kinds of neurodivergence, or just in general for different people's diversity. Some of these ideas, they're based on my experience in cognitive rehabilitation, making the session accessible, but also I see the session as a good opportunity to teach some of these skills. For example, if someone can try out a way of helping them remember the session content, the session's a bit of a testing ground. You know, if summarising and writing notes works for them, maybe they could use that at work, maybe they could use that with family. I guess at the end of the day, really encouraging someone to take charge of using these adjustments, sort of, can they do things to assist themselves and try it out together rather than me necessarily taking charge, always writing them a summary? Could they be involved in writing it with me? So at assessment, I often ask about people's access needs, and I do ask about cognition. You know, what do they notice day to day? What helps them remember? What helps them focus? What helps them get the most out of being with a professional? People often don't know, they've never been asked, or they don't think it's acceptable to have an adjustment. You know, when I suggest to people that we could have a break in the middle of the session, they're often really surprised and, you know, that we could do that. Yeah, of course we can. Sometimes people don't know, but in observing the interactions in the sessions as we get further on, I can say, I've noticed actually, you know, that you're often late. Can we talk about this? What's happening there? Or I've noticed it's really hard to hold on to the session content. What can we do to help with that? I guess difficult to always know, is this a cognitive issue? Does this relate to health? Maybe is it something more emotional, more unconscious? Is there an avoidance? Is there a difficulty engaging that means that that's the reason maybe why someone's late or someone's struggling to focus in the session? I think it's a little bit clearer when we know someone already has a health diagnosis, but often both can be at play. We can explore and experiment together. So I'm going to think through a few areas of cognition, some of the things that I find helpful. So thinking about memory, really important because if someone's got memory difficulties, that might completely disrupt their ability to get a lot out of therapy. You know, if they miss appointments, they're not even there, or if they're not getting much retention but session to session. So practical things about session reminders, prompts, alarms. In terms of the session content itself, what's going to help them to remember the session? Could we do the session shorter? Could we do a lot of recapping, getting them to repeat back what they've understood? Writing notes we write together. I like the idea from earlier about sharing the notes that you write yourself. That's a really nice idea and really transparent. Have some clients who record sessions. I think really important to think with people about what they're going to use these notes or recordings for. There's no point in them just racking up a lot of files or a big file of paperwork. Is there a point in the week where they can go over these notes? With quite a few clients, sometimes we'll make a voice note together at the end with a few key points, and that's often enough. If people really struggle to recall things that have happened outside of the session, maybe more of a focus on what happens here in the session, experiential exercises, dropping into a situation, feeling things in the here and now, so they can say how they feel now rather than how I felt then. Going beyond verbal memory, using visual cues, can they bring in photos, objects, music, getting creative, things that facilitate memory and also make the session more memorable. If getting anxious really gets in the way of remembering, either out of the session or in, there might be a role for some kind of relaxation training, soothing, that helps someone be in the best place to remember. People who are inattentive, really easily distracted, an obvious thing is thinking about cutting the distractions in their environment. I think about this in my clinic room, keeping it simple. If someone's working online, can they get their notifications off? What kind of room are they in? Pets can be a big one. You know, they're very soothing, but can be hugely distracting. For clients who are really tangential, I know there was a comment earlier that sometimes that's how people get to the most important things. I'd say not always. I see quite a few clients who will get to the end of the session and say, that's not what I wanted to talk about, but I just got caught up in it. And I guess we can discuss together a plan for, if I notice them moving off track, do they want me to help bring them back? I think that's something important to get someone's consent for. I think that's true of all of these strategies, getting someone's consent to collaborate on trying something. It might work, it might not. Especially in CBT style work, an agenda and the structure of that, how long we spend on different things, that can really work for someone who's inattentive. It's not for everyone, but some people really benefit. Breaks, pauses, maybe even a shorter session. You know, better to have a bit of session where someone's really engaged than drag it out and lose that. Trying to reduce the need to do lots of multitasking, holding multiple ideas in mind. Working with people who've got language difficulties, maybe trying to slow down our pace, think about therapy jargon that we use, trying to use a bit less of it. I see quite a few clients who've got word finding difficulties, so they get stuck on a word, they get the beginning but not the rest, or they get halfway through a sentence. Discussing with clients how they'd like me to treat that with them. For some clients, they find it helpful if I think I know what they're saying, if I fill it in and give them an example or a cue so they can carry on. Some clients find that incredibly annoying, so best not to jump in unless that's been negotiated. Communication devices, people writing things out, if they're using an electronic reader that speaks for them, it needs a lot more time to slow things down. Yeah, again, some of these strategies are similar across different areas, not relying all on the verbal, drawing things out, pictures, diagrams, getting the paper out. Sometimes it can help to involve someone else who knows the person's communication really well. I've used this when people have a really severe communication impairment or they're really slurred, that sometimes someone else there can really help facilitate their communication. It does change the dynamic in the room, having someone else there, obviously. It needs to be negotiated, but it's a bit different from a couples or family therapy if someone else is there to aid communication and for them to know the boundaries on that. Executive functioning, I think probably people have a lot of familiarity of what executive functioning is. This idea of higher order cognitive functions, I guess I think of it as executive functioning being like the boss of a company or the conductor of an orchestra where the instruments are your other thinking skills, your memory, attention, visual spatial skills. It's pulling them together, usually to work towards a goal. And so inhibition, flexibility, planning and organizing, reasoning, often a factor in other kinds of neurodivergence. as well as some of the conditions I often work with. If people have executive functioning difficulties, sometimes they get really stuck in sessions, they don't know what they want to work on, they can't come up with ideas. Thinking about their own thinking, taking a reflective stance, identifying their feelings might be really difficult. Some people might struggle in one of these areas and not others. It might really vary. Things they learn in the session are a bit too abstract. They can't really take them out of the room. It just doesn't generalize. They might struggle to initiate. They make plans, but it never gets started out of the session, or just can't plan and organize to get things going. And I think that's where we can be a kind of second executive, that we're another person thinking with them, providing that structure, bringing in that support and scaffolding. So yeah, some things that can sometimes help if someone struggles to think in abstract ways, making things much more concrete, using images, diagrams, objects, some similar ideas again. And some people will have one particular area of cognitive difficulty, but not unusual to have more than one. If coming up with ideas is difficult, sometimes I do a bit of structured exploration. For example, if someone really doesn't know what they want to work on in therapy, or they're in a very general space of I just want to feel better, I might help them think by giving them some ideas about things other people in a similar position have worked on, maybe giving them a few options. Do any of those resonate? We could use that as a starting point for more exploration. I work a lot with acceptance and commitment therapy, and using lists of values or life domains, which are the ones that are important to you, that we don't want to lead people, we want to make sure the therapy is what they want, but if they're really stuck, this could be a little bit of scaffolding to get going, to go a bit further. Again, so focusing on experiences in the session rather than trying to generalize it out. That might be really practical experiences, role-playing, behavioral experiments. Can you monitor yourself here and now? So maybe still using metaphors, but make them a bit more concrete or personal, related to someone's interests. If someone really struggles with self-awareness, monitoring themselves, therapists could help with that. They can be a kind of external monitor, maybe noticing when someone's moving off track with permission, feeding back, helping someone to notice their emotions. I noticed a shift in your body at that moment. Can you tell me what you were feeling? That you can model that process. Planned opportunities to give feedback or seek it from other people, so it's not too confrontational. For someone who's really impulsive, might need a lot of clarity on the boundaries of the session, maybe a lot of prompts as we're coming to the end of the session. For someone who really struggles to get started or initiate, the session could be used for some accountability, I guess with permission. Do they want to break a task into a small piece and maybe plan to do it between now and next time we meet? Maybe together breaking a task down into pieces, doing some planning and organising together. I guess some general ideas, kind of involving someone else in the therapy, maybe as a kind of backup coach or someone who supports engagement or following things up outside of a session. It does need some careful negotiating. Who's the right person to do this? Can they commit to it? How does that affect this person's privacy? Some people may have someone they really want involved. It's not for everyone. This came up earlier in the other sessions, that working with people with these needs, they might not know what services are out there, things like access to work, what benefits they might be entitled to, or they might not be initiating, seeking these things. So I think it is useful for us to have that knowledge. Whether we support ourselves, like writing PIP letters, or whether we know how to signpost someone to somewhere like Citizens Advice, where they can get that support. I guess we'll try our best to support people to access therapy. There might be some situations in which therapy just really isn't accessible. If even with a lot of memory support, someone really can't remember much session to session, there might need to be a sensitive conversation about, are they benefiting? Is this how they want to use their time? Would something else help them better? Maybe some kind of social support, maybe being involved in a group, maybe something else in their environment might have more of a benefit than the time and energy that goes into a one-to-one session. Some challenges or dilemmas thinking about some of these practical ideas. It can feel a lot more directive than a lot of us would usually work, or maybe we're trained to work. It can feel a lot like taking an expert position. There's a challenge there where sometimes we do know ideas about ways of making therapy accessible, of adapting, but the client doesn't know, they don't know they need. I think we do have some responsibility to share that and just, to share that knowledge to help. I think it's not either or in terms of providing cognitive support or exploring whether, say, forgetting is a more emotional process. There's a bit of a change in emphasis when we know someone has a cognitive difficulty, but I think, that, as I'd mentioned before, to try things out, to explore, to recognise when the problem's there and when it's not present, when are they more able to focus. I think we can still provide a memory aid and explore some of the unconscious things that might be impacting on someone's memory or other skills. And I guess if some of these accessible elements don't fit with your particular model of work, there might be other ways in which someone can get this kind of support. Maybe it comes through coaching, occupational therapy, maybe accessing a condition-specific support group. I think there are lots of different routes to wellness and living well with a condition. I'm going to set, the slides will come around to everyone. These are some resources that I like, some books or papers or chapters that I've drawn on. There's not loads of research in some of these areas, so it's a mixture of some of this research, but also a lot of my own clinical experience and stories from clients. Any questions? I guess technically we've got until past, so we'll probably have a break in kind of 5-10 minutes. Brilliant, yep, so up to 10 minutes or wherever people want. Any questions online or in the room?
I've got a bad voice, so this is ridiculous.
It's okay, I can hear you, I can repeat.
You can hear me, good. It's less a question and just something that really came through for me that I feel like warrants repeating, which is around, I think in my core training, it's very non-directive and very much, never suggest, never seem like you're telling someone their feelings, never get anyone else involved, lots of nevers that I'm thinking of. And I just think that through this, it really is quite empowering to think about, well, there are ways that you can offer and that emphasis on consent where, contracting for if you get stuck, is it okay for me to suggest the word that you might be thinking of? Does that feel okay for you? Because I just never do that. And maybe I can with consent. So that's actually something that's really clicked for me, and I just wanted to share it really, since no one else had their hand up. Don't want to take up space.
I'll just see if I can summarise your point. You were talking about how being trained to be really non-directive, and that's common to a lot of therapy training, that you don't make suggestions, you don't bring in ideas or suggest how someone might be feeling, and just this idea that you maybe could work a little bit differently with consent, suggesting something, trying something out, that might feel really helpful. Have I covered your point, I think?
Yes, absolutely.
Yeah, and I guess different therapy training is different. I think kind of the way that I've trained often, and especially being involved in rehabilitation, it is quite practical. People don't know what their process is of developing and living well after a condition, that they're looking to me for some guidance, or at least what's worked with other people. But yeah, I guess maybe it's the way of sharing it, getting that consent. Do you want to find out about this? Or even can we learn together? Sometimes I work with people with conditions that I'm not as familiar with. Let's look at what's out there. Let's try it out together. Hi, a question online?
No, I was replying to your comment. I think it's always worth really interrogating when we talk about things like, I was trained to be non-directive. It's a bit like, oh yeah, in my modalities, we are told not to self-disclose. What they actually mean is you've been told to behave like white cis men. You are directive. You will have a contract. You will have safeguarding rules. You will direct all the way through the session. But you will have been told, but making it more accessible, or bringing this up, or being anti-oppressive, or not behaving in the way that the white, straight, cis men who invented your modality decided. That's directive, but this isn't. It's really similar to disclosure. So sitting with it and working through, what do they mean by non-directive? Because quite often they don't mean non-directive at all. And if you think about the direction you're allowed to do in session, and then the stuff, it's always about the stuff that helps marginalise people. That's directive, but this isn't.
Oh, I love that. That's such a powerful point. Yeah, because we are directive in sessions. We decide when they start and stop. There is a power balance, but do we only think about non-directiveness when it comes to supporting people who are marginalised? That seems ridiculous, doesn't it? But yeah, and I'm not telling anyone how to practice, if these ideas don't fit for you, but it's interesting to think about. Hi.
I'd like to take this point a bit further, because I'm thinking about where we might be in conflict with some of our principles and understanding that some of the neurodiversity that is a result of a brain injury or something like that might require us to work in a way that might put us in a conflict with some of our basic principles. And I'm thinking about this right now, where, for example, being directive, or the overlap between different parts. If you work in a multidisciplinary team, you as a clinical psychologist might be doing some work that an occupational therapist would be doing, and that's perfectly legit for the occupational therapist to say, okay, you might need these and these tools and so on, and you as a therapist might find that too directive or something like that.
Oh, for sure. There's certainly some roles that I work flexibly, and I think working in a multidisciplinary team, I'm used to some sharing of roles, but there might be some things I think that doesn't fit as being a psychologist, and doing that it's more appropriate from someone else. But depends if there is someone else who can do it. I used to think, writing long pip letters wasn't part of my job, but I do see it as part of my job now because it's very therapeutic and I can. Yeah, I guess that's an interesting point about, if somebody needs access, needs support to engage, but it conflicts with our principles as a therapist. I think we have some responsibility to make reasonable adjustments, but there may be limits, and not everyone's going to be the right therapist for someone. There are a lot of different approaches, and like I said, there might also be other things that will help someone that are not psychotherapy. I think we're coming to the end now. Okay, thank you all so much.